Hello, my name's Dr. Vicky Cleek and I'm a general adult consultant with a special interest in adult ADHD. Many people with ADHD end up taking a combination of a stimulant and an antidepressant. And today I want to talk about the risk that's often overlooked when combining these two together, mild serotonin syndrome. You hopefully have been warned about serotonin syndrome by your clinician and told that the risk was low, but in clinical practice, mild cases are often overlooked as symptoms can masquerade themselves as having anxiety, side effects of your medication, or things such as getting a tummy upset. So in this video, I'm going to explain why, what to watch out for, and what you as a patient and a prescriber can do about it. So many people with ADHD are prescribed both an antidepressant, often an SSRI medication such as fluoxetine or sertraline for depression, anxiety and OCD, as well as their stimulant like methylphenidate or dexamphetamine. Stimulants already raise your blood pressure and your heart rate, particularly when you increase the dose, and that can overlap with signs of serotonin excess. So mild features of serotonin excess, for example, restlessness, anxiety, a tremor, having a tummy upset with diarrhoea, may all be misinterpreted as side effects, ADHD symptoms, or general stress. And patients often do not volunteer parts of their history, for example, that they've started taking new over-the-counter medications, such as St. John's wort. And because serotonin syndrome is not well known to patients, they may not report a new tremor, a twitching, or a subjective muscle tightness unless they're specifically asked. Mild cases are very easily overlooked, and by the time they become more severe, a hospital admission may be needed. And we want to avoid that. So what is serotonin syndrome? Serotonin syndrome happens on a spectrum. It can be very mild, but in extreme cases, it can be life-threatening. And so that might be very relevant if anyone takes an overdose of their medication or if they go out and use party drugs such as cocaine on top of what they're already taking. Key symptoms that occur include those of mental state changes such as restlessness, agitation, anxiety, headaches, and confusion. There may also be signs of autonomic overactivity, such as having an increased heart rate, having a higher blood pressure than normal, sweating, a mild fever, flushing, nausea, diarrhoea, and dilated pupils. And then there are neuromuscular signs which hint strongly that this might be a problem, such as a tremor, having brisk reflexes, rhythmic joint jerking called a clonus if your ankle tendon is stimulated by brisk flexion, any muscle spasms called myoclonus, or having rigidity which occurs in more severe cases. A characteristic physical test to check for clonus by briskly dorsiflexing the foot leads to rhythmic oscillations. Reflexes may be brisker than expected, and onset of these changes is usually soon after a dose increase or addition of another serotonergic drug, although in mild cases you might evolve these symptoms over a day or two if your serotonin accumulates in the body. So why do SSRIs and stimulants raise the risk of this? Well, some stimulants, especially amphetamine derivatives, may have indirect serotonergic effects or interact with systems in the body that stops the clearing away of the serotonin. The risk is higher when a person is on multiple serotonergic agents, such as migraine medications, some opioids like tramadol, St. John's wort, and other herbal supplements which are aimed at increasing your serotonin levels. And the risk of serotonergic syndrome increases with any dose escalation or addition of a new serotonergic agent. Although rare, the real difficulty is that mild cases are likely to be under-recognised. So how well can we detect mild cases? Well, from clinical experience and available literature, we as clinicians often don't ask specifically about whether a patient has tremor, twitching, clonus, and patients usually don't volunteer them. We might attribute any restlessness or agitation we see to ADHD or a worsening of anxiety. Any gastro symptoms like nausea and diarrhoea are often dismissed as incidental by patients, for example, having a holiday gut, and we may skip the neuromuscular examination, checking for your reflexes and whether or not you have clonus in outpatient settings or if care is given online. And we may not fully review all medications by asking about additional over-the-counter medication or herbal supplements since you were last seen. And then once mild symptoms appear, we may not recognise that pattern unless we are primed to think about it. So what can we do? Well, in terms of your prescriber or psychiatrist, it's important to do a baseline assessment. Ask about any tremor, twitching, restlessness, bowel symptoms, sweating or palpitations that have occurred since any increases in medication. It's important to do a quick neuromuscular exam if possible to check for clonus and reflexes, and it's important to review all medications, including over-the-counters and supplements, each time a patient is seen. We already usually check the baseline vital signs such as heart rate and BP, but we should be alert to any changes of this being part of a serotonin syndrome. It is really important to inform our patients and provide written handout about signs to look out for, and to ask proactively in follow-up with questions such as, have you had any new tremors or twitching or any muscle jerks? We should encourage patients to present early rather than delay if they notice any new symptoms. And we should titrate medications using gradual dose increases, especially if a patient is already on other serotonergic agents. It's important to avoid large jumps or overlapping high doses without good monitoring and follow-up. If any signs of serotonergic syndrome do occur, we need to pause any increases and reduce the serotonergic load, as well as monitor carefully. And obviously in any moderate or severe cases, or if in doubt, consider whether a hospital referral is necessary. Your clinician should be documenting carefully and reviewing all other contributing factors. And for you as a patient, what should you do? Well, if you're both on an SSRI and a stimulant, then it's important to watch out for any new or worsening tremors or shaking. If you feel twitchy or have any jerky movements, any new unusual restlessness or agitation, increased sweating without a clear cause, any new palpitations, a faster heart rate or blood pressure changes, any new diarrhoea or nausea without another explanation, muscle stiffness, tightness or feeling generally weird. So changes to mental state, including confusion or agitation, any of these, if you notice them, don't assume it's just a normal side effect. Raise these explicitly with your prescriber. Ask them, could this be a mild serotonin excess? And should we pause or reduce one of my medications? Because treatment is best when done in partnership between you and your clinician. And you should feel able to ask them any questions, no matter how silly they seem to you, because they won't be. So as a short case example, Jane is a 28-year-old lady. She's very slim. She's been taking 40 milligrams of lisdexamfetamine and escitalopram 10 milligrams for her depression, which was started prior to her diagnosis and treatment for ADHD. Her GP increases the escitalopram to 20 milligrams after she's seen by him with a lowering of her mood. And 2 days later, she notices a shakiness in her hands, some jerkiness in her feet, and she's got some mild diarrhoea. She only reveals this several weeks later at her ADHD review, and on examination her pulse is elevated at 100, she's got a blood pressure that's higher than baseline at 119/71, and there's some ankle clonus and brisk reflexes. She has, and up until now, attributed her diarrhoea to something she ate, but at review you ask, have you had any tremor, twitching or jerks that are new in onset? And she says yes. You both agree to pause the increase in the escitalopram and stop the lisdexamfetamine in the short term, monitor her symptoms, and you find that over 24 hours they have resolved, with her blood pressure and pulse going back to baseline and the jerkiness feeling disappearing. You consider reintroduction much more cautiously or using alternative strategies, ideally in partnership with Jane's GP. Now that's a mild serotonin syndrome. scenario that's been caught early. But if no one had specifically asked and Jane had not noted these new symptoms, it may have gone undetected for a prolonged period of time. And if she had added in some extra medication, such as an opioid, later down the track, which further increased her serotonergic load, then things could have been very different. It's important to say that severe serotonin syndrome with hypothermia, rigidity, and even organ failure is very uncommon in therapeutic dosing. But the data on mild cases is pretty limited because they often go unreported and undetected. Some symptoms may overlap. Side effects of SSRIs or stimulants can masquerade as serotonin syndrome, and not all tremors or GI upset indicate a serotonin syndrome either. So the differential diagnoses remain very broad, but it's important to be vigilant. Clinical benefit versus risk must always be balanced, and vigilance is the goal, not paranoia. So the take-home message is: 1. Serotonin syndrome is a spectrum. Mild cases may masquerade as side effects or symptoms of ADHD or anxiety. 2. Combining SSRIs and stimulants heightens the need for vigilance for emerging mild serotonergic syndrome. 3. Clinicians should ask specific questions and perform neuromuscular checks if concerned, and review all medications each time a patient is seen in clinic, particularly if there are any dose increases. And 4. Patients should be informed about any key symptoms that are new and encouraged to communicate these early. 5. Early detection allows intervention before escalation to dangerous toxicity. And that's how you remain safe on combinations of common medication that all can increase your serotonin levels and reduce the risk of hospital admissions. I hope you found this run through of serotonergic syndrome useful. It's not to scare, it's to share. Take care until next time.